today. This session is about the bridge we've helped build between primary care and ophthalmology using autonomous AI. So this is how SSM Health and Digital Diagnostics have partnered to close care gaps in diabetic eye exams and improve outcomes at scale. So I am Katherine Fairchild. I am the Director of AI and Machine Learning here at Digital Diagnostics. My work focuses on creating clinical-grade AI tools that truly work in real-world healthcare settings. So not just in theory, but everyday practice for both patients and providers. And before we get into it, just a few administrative items. First, this webinar is being recorded. And second, if you'd like to ask a question, please do at any time using the chat feature. Questions will be answered at the end of the presentation. We'll have a discussion and Q&A. Finally, if you would like to connect or schedule a personal demo, just type meeting into the group chat and a member of our team will be in touch after the meeting. So without further ado, our mission here at Digital Diagnostics, it's fairly simple, straightforward, but far-reaching. We aim to benefit patients by transforming the accessibility, affordability, and quality of global healthcare. We do that by embedding clinically rigorous AI into diagnosis and treatment workflows. Our flagship solution is LumineticsCore. So this is an autonomous AI system that detects diabetic retinopathy and produces a diagnostic report at the point of care. It's FDA-cleared to make that diagnosis without a human reading the images. So without that human in the loop, this is a game changer for expanding and scaling access. So what do we mean when we talk about artificial intelligence? AI in general refers to computer systems that have been trained to mimic the functionality of human intelligence. So recognizing patterns, interpreting data, making predictions. In our specific case, it has been trained to analyze medical images and return a diagnosis. So training AI is really about feeding it a lot of data so it can learn to recognize those patterns. And you can think of this very much like teaching a child how to read. So you show them a lot of books, and eventually over time with your tutelage, they start to recognize words and then meaning and grammar, and they put it all together in order to be able to read themselves. So these images of, is this a cat, classification, what is in the image, object detection, which pixels belong to which object, image segmentation. These are all different functionalities that artificial intelligence can be trained to perform. And here we have done that. So we extend this concept of teaching artificial intelligence how to mimic these human capabilities into healthcare. And specifically, our models are trained on high-quality color fundus images and include advanced capabilities like those you saw on the slide before, image classification, object detection, and segmentation only on fundus images instead of cats. So we can also do things like locate anatomical structures like the optic disc and identify lesions. So this is all foundational to clinical grade AI. How does this work in the real world? LumineticsCore uses that AI to analyze a color fundus image and determine with that image whether or not a patient has more than mild diabetic retinopathy. So the diagnosis is delivered in minutes during the same clinical visit. But we don't just do the image interpretation. Before the diagnosis is made, our system performs very strict quality assurance. So are these images usable? Were both eyes imaged correctly? Is there enough visibility of the key features we need to make that diagnosis? So these quality assurance steps ensure that what we're delivering, that diagnosis, is in fact clinically reliable. And then once the image passes quality checks, the model evaluates multiple features. So everything from red lesions, hemorrhages, exudates, to classify the disease severity. So this mirrors this process that the model is using to evaluate those images and return the diagnosis. Really looks like how a trained ophthalmologist might also assess retinal health. Again, that AI has been trained to mimic the human behavior. And in fact, LumineticsCore has been validated to perform at least on par with trained clinicians. So this is very important. This means that patient care can be scaled with the use of AI, but without any concern about potential compromise to safety or accuracy. And now to tell you what that actually looks like firsthand to implement, I am thrilled to introduce Dr. Joseph Eckelkamp. Dr. Eckelkamp is a board-certified family medicine physician at SSM Health, where he has been serving the St. Louis community for over 2 decades. He is known for his deep commitment to preventative care and for being a true advocate for innovation that puts patients first. And today he will share how SSM Health brought AI into the primary care setting, not just to improve the metrics, but to improve lives. So please join me in warmly welcoming Dr. Eckelkamp.
Thank you for that warm introduction, Katherine. I really appreciate it. So first to start, I have no final interest in digital diagnostics. My perspective today comes purely from my clinical experience and the clinical experience of SSM St. Louis. Our focus has been on practical, patient-centered implementation, and I am excited to share what we've learned on our journey together. SSM serves millions in Missouri, Oklahoma, Wisconsin, and Southern Illinois. In St. Louis alone, we operate multiple hospitals and clinics. There are almost 70 cameras across the SSM system, with 30 of which I am overseeing. And as many of you may be aware, St. Louis is a very unique place where there is a large fragmentation of overall socioeconomic backgrounds across the in various areas, which then have created some of the most economically challenged neighborhoods in America, and very close to some of the most economically privileged areas in the area. Which leads to some really unique struggles as a whole. When we look at the areas of top healthcare concern for individuals living in St. Louis County, the biggest ones are mental health, heart conditions, and diabetes. These big three are consistent across many cities and are consistently top areas of concerns for America as a whole. Oftentimes, while mental health is a big one, but oftentimes it comes as a result of health conditions that come from living and in less advantaged areas. Heart conditions, diabetes all come together, and as a result, through taking care of diabetes, through taking care of these other issues, we can overall decrease the amount of health burden that our patients and our community members, our neighbors, our family members are having thrust upon themselves. And overall, day by day, we want to keep these individuals engaged in our community. We want to keep them engaged with each other so that they can do what they enjoy most, that brings these communities together. We know objectively that individuals with diabetes have 2 to 3 times the rate of mental health issues. We know individuals with diabetes who are newly diagnosed come oftentimes with complications established. Eye complications are present in 20% of individuals with the onset of diagnosis of type 2 diabetes. So how can we reach them when they're busy, when they're engaged in their communities, when they have other things to do than spend time in the healthcare world? So oftentimes, up until now, our patients wouldn't obtain the screenings that they would be asked to do. They would say, my vision's is fine. I don't need to see an optometrist. I have diabetes. Okay. I know there are all these other things I need to be doing to make sure I'm taking care of myself. I don't have time to do those. My primary care is my trusted source of my contact with the healthcare system. To go to another specialist that is already fragmented and it doesn't have a direct referral is scary, and there now needs to be that new level of trust that's built amongst the team. And in addition to that, often in St. Louis specifically, there's significant transportation issues where many of these individuals do not have the ability to get from their house to a optometrist's office for that regular exam, and it requires them to take significant extra steps to get there, as they can't afford the Uber, they can't afford Lyft, they can't uh, have a right now with what's going on in St. Louis from the recent tornadic activity and destruction that's happened. Their car may be in the shop, they can't buy a new car. Their community is isolated, so they don't feel empowered to ask their neighbors to drive them from their home 5 miles down the street to the optometrist office for that evaluation. So they fall through the cracks. It's not a trusted source, so they don't know how to consistently engage in the effective screening. As a result of this, we looked at various solutions for this. We needed something that was reliable. We needed something that was highly specific, highly sensitive, that would uh, bring the providers to trust the device, but as well as to allow our teams to have that trusted relationship and empower that trusted relationship between the primary care provider and the patient, bringing the care all in one place. We needed to bring these eye exams to the point of care so that we minimize the burden on our patients for their extra testing, so that they can be engaged in the community, so they can be fathers, they can be sons, they can be daughters, they can be mothers, they can be pastors who are and pillars of the community that bring the community together. By providing real-time answers, we're empowering that trust. And lastly, this is something that we needed to ensure that anyone in the clinic would be able to operate. We can't. This is a full team effort. Having one or two people able to perform the test leads to areas where there's delays in the clinic. If someone's out due to illness or otherwise, the exam's not getting done. We really need to make it as simple as possible, and also that simplicity empowers trust to our patients. So as a result, we turned to digital diagnostics to eliminate these barriers and solve for some of these problems on trying to ensure that as the device was implemented in our clinics, it was highly sensitive, highly specific, that we had the point of care solution that offered real-time answers that could be operated by anyone in the clinic, providers, yes, but also our rooming staff, our RNs, and even our front desk. And that's where the autonomous AI that digital diagnostics has really made has really empowered our teams to provide the healthcare that our patients deserve, and allow our patients to continue to be part of the community and to be filling the roles that they need to fill through their day-to-day. So with this isn't just an eye and I'm sorry, backing up. So we've talked about why SSM chose LumineticsCore through digital diagnostics, because it's an autonomous AI. There's no specialty required. There's no extra interpretations needed. The result is there. It's real time, but where we can talk to the patients about why they need to do the next step, why they need to see the optometrist, because we're worried about their eyes getting worse, because we're worried that they may lose their vision. Or on the flip side, that no, yes, you need the screening, but we don't need you to go anywhere special. We can keep you in the community doing just coming back for your normal follow-up and minimizing those delays. This seamlessly integrates into our primary care workflow, because not just is a order in our EMR, which happens sent directly over to Luminetics' digital diagnostics camera. It's also the results are sent and back to our EMR and directly integrated. And no matter where the patient is in SSM, as long as they're able to come to that first visit, we can take care of them. This isn't just an eye exam. This helps us talk to our patients about why they need to do these next steps, why they need to have the additional evaluation and potential intervention that will save their vision. As I mentioned earlier, the EHR implementation is seamless. The order is generated by the rooming staff. The exam is performed. And the results are then directly transmitted back to our EHR for integration, for evaluation, for the result to be passed on to the patient. No additional interpretation is required. The result is positive, negative, or indeterminate. And if the result is indeterminate or positive, the patient is then referred on to that next level of care so that we can make sure that their vision is being preserved. And now we have reason to refer them on to that next place of care that the patient can buy into. That's not just I need screening. It's you need evaluation to make sure that we're going to keep your exam because we're seeing something that's might be problematic. Since we went live with LumineticsCore back in May of 2023, we have performed about 11,000 exams. First May was a little bit of a learning period where we started off slow, but gradually really built and the program to where we are doing these exams every other year on our patients on a consistent basis to make sure that they are getting the care that they need and that they deserve. And as a result of this, prior to implementation, our baseline was in line with national averages. 50% of people who had diabetes over 18 had their regular screening. By the end of 23, we jumped 10%. By the end of 24, we added another 5% onto the diagnosability in St. Louis alone, jumping to 67%. And by the end of 2025, we hope to climb up to 75% because the patients trust us, they're confident in our teams, and our teams are confident in the technology and delivering the news so that patients are getting the care that they need. More exams, more diagnosis, more interventions, more sites saved, the greater the ability for these patients to then be part of the communities, not just from the standpoint of minimizing those extra exams, but also we're now empowering these individuals who would have otherwise had vision-threatening diabetic retinal changes to get treatment in that timely fashion so that they preserve that vision so they can still continue to be as present for their families, present for their communities, and engaged as possible. So many patients I hear over and over say, if I had known I had diabetic retinopathy prior to their vision-ending event, that they would have sought treatment because so many people are just positively terrified of losing their vision. For about 30% of America, they would rather lose their life than their vision. It's such an important part of how we interact with the world around us, how we interact with each other, how we interact with our surroundings, that to go from a lifetime of having vision to all of a sudden having significantly limited vision is terrifying for these patients, and this empowers them to seek that care at the time that's right for them. So what lessons can we take away from this? We can start by asking by what care gaps do we have? How can we work with our teams to ensure that we are moving in the right way to best care for our patients? When we started talking about the various solutions and thinking about how can we overcome this, we very quickly realized that we needed a solution that would integrate with our workflows that we needed to bring in-house because the barriers of time cannot be solved by partnership with other outside organizations. We needed something to be present at this point of care. Ultimately, we also recognized that by having something that was at the point of care, that we needed to empower our teams to have that extra resource, the extra time to be confident that they're not interpreting the results because many times they don't feel qualified for it. And that's where the autonomous AI comes in. It extends our primary care teams. It gives us the ability to diagnose, to counsel, and to ensure the patients are getting to that next step so that the optometrist, the ophthalmologist can maximally be used for their level of care. When again, continuing to understand what the various areas where we are looking at the various vendors available, Luminex came to us with a fantastic end-to-end onboarding, staff training, and clinical support that on an ongoing basis that allowed our teams to feel confident in the partnership. And that's where the collection of all these really brought together that trusting relationship between Luminetics and Digital Diagnostics with SSM Health and allowed us to then be confident in our ability to expand to our healthcare teams. and our healthcare teams explained it to our patients. So thank you for letting me share our story with you. We're always learning, and we're excited to help you start on your journey together. Please, I'm happy to take any questions that you might have, and looking forward to working with you.
Okay, thank you so much, Dr. Eckelkamp. It's really fascinating to hear about your experience. And at this time, I would love to open the floor to discussion and Q&A. If anyone has any questions, please let us know. It looks like, give me 1 second, we have one coming in. So we discussed the tangible improvements after the implementation of the AI. Are there any intangibles, like how your relationship with the specialist community has changed with the AI coming in?
Yeah, absolutely. And that's a really neat one that kind of came of this as well. SSM in St. Louis recently acquired SLU Care as well, which has a dedicated optometrist and ophthalmologist practice and residency. Um, as a result of this process, not just are we delivering that high quality care, but when we have coordinated with them, with some of the local optometry and ophthalmology facilities and practices in the area, they all are actually really excited about this process because they then are more reassured that the referrals that are coming in are meaningful, that they are impactful, and that they're not just another routine screening that uh, from the ophthalmology standpoint, they would rather see the cataracts, the glaucoma, the people with diabetic pathology that they can intervene on. They oftentimes are finding that more meaningful as they move forward, and as well as the optometrists and the other community ophthalmologists outside the academics facilities setting. They're seeing that this is a neat relationship where they can be empowered to provide the care at the highest level of their licensure and most completely impact and thoroughly impact the patient population that they need to see.
That is a great answer. Thank you. Another question we've got, what measures did SSM Health implement to monitor and evaluate the performance of LumineticsCore?
As a whole, first things first, at the end of the day, we needed to make sure that as time went on, that we were seeing that our diabetic eye exam compliance rate was increasing over time. That's an easy one that many of us are already measuring in some way, shape, and form. In addition to that, we measured how often the exams were being completed per clinic, and also how are our teams completing the exams. What's the sensitivity? What's the diagnosability of our teams? And as the continued discussion of yes, these exams are happening, they're effective, they're catching them, they're catching diabetic retinopathy, having feedback on how many of these positive results are occurring was really eye-opening because in SSM St. Louis, we had about a 20% positivity rate, which is a pretty sizable chunk of individuals that we are now saving their vision on and helping them get to that level of care at that time, at the time that they need it rather than otherwise. Part one, where they would otherwise wait for the exam. But on the other hand, there's are the other group of patients who didn't have that positive exam that now are going back and saying, "Oh yeah, I saved the time so that I didn't need to take time out of my day." They say the specialist schedule, so now those people with the glaucoma, the cataracts, the diabetic retinopathy who need that additional intervention can get in sooner, more quickly, and more effectively.
Thank you. Okay, lots of questions. Now, this is an interesting one. Did you get pushback from admin in implementing an AI system, and how did you win them over, if so?
Our administrative team is very collaborative. SSM Health is going into the value-based world quite heavily right now, and the idea of population health is a core tenet of who we are. Many of our hospitals are community hospitals, and many of our practices are intimately involved with the community in some way, shape, and form, oftentimes in many of the at-risk neighborhoods. As a result, this has been a little bit of our the idea of reaching out to patients at where they need it, being part of the community, being part of their friends, their family, their social network has always been a little bit of an SSM mission. So with that, the idea of being part of this and being engaged with and bringing something to our patients has been foundational for the to our administrative work. And as they continue forward, they appreciate, they understand that, they know that bringing things from to the point of care as much as possible is critical to being part of that community.
And I know you sort of indirectly touched on this with one of your earlier responses, but more directly, how has the screening time impacted the rooming turnaround time?
Consistently, well, there's two different ways to approach this. Many of our teams are approaching this screening from the front desk. They're seeing that this and identifying this patient at check-in so that the patient is then checked in, taken to the screening, and then they room for the exam, and then they are either put back into the waiting room or they are moved into the exam room quickly. The average screening time at SSM Health is around 5 minutes. So pretty minimal. And when there are delays, when there are other items going on, the exams are quickly brought in patient care. The exams are done while there's that delay, so that we're keeping the patient moving, so that the exam is completed perhaps before the patient is even roomed and the room is ready for turnover. There are some of our clinics that do it on the back end where the patient is has the result given to them after checkout, and at that point in time, they wait for the exam result. We talk about that briefly, and then they're on their way, and it works well as in that facet too. And then lastly, we do have a couple of clinics that actually who really grabbed this by the horns and said, "This is awesome. This is what we needed." And they're having patients come in separately for a exam for whatever reason, where the patient says, "I'm running late. I need to go to a meeting. I need to go to a wedding. I need to hop on a plane." And they're setting them, "Well, okay, that's fine. We understand that. We want you to come back and make sure that you get the screening. Let's set this up for as a nursing visit so that this can happen."
And then how within the EHR do you differentiate between screening as opposed to disease surveillance?
Also, in our EHR, we use a problem list to try to distinguish what is going on. So after the exam comes back, positive or negative, the result of positive is then put onto the problem list so that that can be followed forward. And as that is, and then as the team reviews that longitudinally, if they have that diabetic retinopathy on the problem list, they are now excluded from these exams. And we're more aggressive about ensuring that an individual has the results in our EHR, that they have that connection, and that if they don't have that connection, that we're trying to help facilitate that in some way, shape, and form.
Awesome. I want to ask you about how during this integration process, how did you manage the change and engage the clinical staff while this was going on?
Um, I'm sorry, would you mind repeating the question again? I'm sorry.
Sure. So the clinical staff, obviously, this is a fairly big adjustment in the typical workflow. So during that time, how was the change managed? How did they take it? How did the engagement happen with them?
And the clinical staff, as they learned about, they heard it. I think they were initially a little wary of it because this is something new. This is something different than what they've ever done before. They've all done testing in some way, shape, and form, but it's anytime it's a machine that they're interpreting, that they're hearing, that they are needing to help with, it's a little bit different. It's a little bit odd. And the ability for the team to kind of discuss superficially, at least with the results, is a little bit on the odd perspective from their perspective. But on the same token, it's not all that much different than the point of care rapid flus, the point of care streps, the other point of care, the urine analysis that we do on a regular basis. And once so after that initial education, and Rebecca, our liaison, has just been an incredible resource to help, one, provide the education, two, to offer training as as new individuals are brought on, and three, continued evaluation of what's going on, what's working, why are we having issues, why are we not having issues, and where are the successes that we can learn from, and some of those best practices that we can share. So the staff ultimately said, okay, yeah, great, we can do this. We can, and we started off primarily in the rooming staff, and allowing them to complete the exams, and at least that way, somebody was always going to be able to complete the exam. And they took it, ran with it. Once they started doing it, they felt more comfortable. The exam time went down dramatically, and they felt empowered to start having these conversations with our patients. Then the next step came, and we said, well, truly, this is something that is a almost point and click type test. The patient, you sit the patient down, you position the patient. Is there a reason why the front desk and some of the other ancillary staff members can't help participate in these exams? And that was actually a place where things got interesting, because as a whole, the front desk oftentimes was feeling like they're there, they're helping engage with the patients, they enjoy the patients, but that they're not necessarily participating in some of the patient care, even though they're the face of our offices. And I think many people would say they're probably some of the most important people as patients are welcomed into our clinics. As a result, the front desk team started to be asked to do these exams because they had a little bit of downtime. They had the staffing to support that. It was a slower day, and they took it and ran with it. They said, they across the board, I can be involved in the team here. I can be not just someone who's up here in the front room, checking people in and checking people out, but I can actually help perform some of the tests. This is cool, and now I can talk with my patients about it, and talk about how we can work together as a team. That's really cool. So I can set things up for the healthcare team behind us, the nurses, the physicians, the PAs, to have the conversation with the patient, and then help facilitate some of those other ones, and have appropriate conversations with the patients separately. They're not clinical, they understand that, but they are always looking to say, hi, hey, how was your experience with doc so and so, and checking in on the patients. So they are some of our best advocates now.
That is a really cool story. I'm glad that question came up. The next one we've got in is, how did you find the service model here at Digital Diagnostics different from other vendors? So especially with regards to customer support going through the process.
Customer support has been fantastic. I cannot speak highly enough about our partnership with Rebecca. She has been holding regular touch points with us, talking about the successes and the problems that we're having on-site support periodically as needed, constant monitoring of where clinics are being successful, where they're not being successful, and allowing us to engage with those clinics that may be having some struggles, and identifying them on a month by month by month basis, so that we can have those conversations to help empower the team, or to figure out what's going on with their camera when there is an issue. There, on the flip side, there is also a technology called Sphere DX that comes with Luminetics that allows for individuals to go and review the pictures by PDF. That Rebecca and the Luminetics team does do point exams, point reviews, and to review these exams, to one, make sure that there is a QI component to it, so that the sensitivity, specificity continue to be high. Two, so that if in the QI process there is a exam that for whatever reason was incorrectly read, that is passed on to our patients, so that we can continue that trusting relationship. And then three, when kind of in a new way of being neat that we haven't touched on from a clinical diagnosability standpoint. She has actually gone in and looked at some of these pictures in those clinics that are having issues and saying, yeah, I see why this clinic is having an issue from the picture that was taken. There's a smudge on the lens. There's a couple of dust flecks that need to be cleaned off, and let's just go and talk to that clinic real quick. And a easy fix, easy solution that is certainly a easy conversation to have. If there's an IT solution, hey, there's a issue with a connection between point A, point B, for whatever reason, let's work through that. And we identified that because all of a sudden they went from 2 or 3 exams a day down to 0 for a week, and what happened there. And now we can have that proactive conversation, which is just fantastic.
Awesome. So we have a question about dilation. So is dilation performed in the clinic? And if so, how do you determine the need for it?
Sure. Excellent question, and an important question. With Luminetics, what they advertise is that without a dilation protocol, the exams will be diagnosable about 70% of the time, and that's consistent with what SSM is seeing. We're right there at 70% over these exams. We are starting to investigate a dilation protocol. We are piloting it at a couple sites right now, and still in the infancy. Overall, right now, I can say we're seeing some favorable results, consistent with what Luminetics was advertising. And we're right now in the process of trying to understand what the next step is, whether that's more time or otherwise. As a whole, in the literature, there's a couple different strategies that are there. One is a reactive dilation protocol where an individual comes in, they have a non-diagnostic exam, and then they go ahead and have a dilation either at the next clinic visit that year, or if you have time and the ability to go ahead and just dilate them there. When the individual is has the initial exam on rooming, that oftentimes is a great time to do it because you have a non-diagnostic result and you can dilate, and then they sit in the room for 15 minutes while they're talking with the doc, and there you go. Or the nurse practitioner, and there you go. Now you're ready for the repeat exam on checkout so that we can ensure that the patient's captured and has that dilation. There are some other neat dilation protocols that are out there that have partnered with digital diagnostics that I think are worth evaluating, whether it's on a proactive stance. And that's and that has been published in the literature out there and is worth looking at. We're still trying to identify and figure out exactly what our strategy is going to be based upon the couple pilots that we have.
Awesome. Thank you. That was really thorough. The next question is about whether or not, obviously you guys are an innovative healthcare system. SSM Health specifically sounds like you were ready to go in on AI. Do you have a plan? And if so, what does it look like to continue the use of AI beyond diabetic retinopathy to other areas of primary care?
Ultimately, AI is here to stay, and it needs to be respected. It's one of many different ways where we are needing to take the provider shortage that we will be having over the next 10 years and try to extend our providers more and more and more so that our communities can actually be taken care of. I believe by 2036, if I'm remembering correctly, the primary care shortage will be nationally about 40,000 primary care providers. And that's just a huge number to think about. How are we going to take care of all these patients? How are we going to take care of these communities that are only going to get older, who are only going to get more complicated, have more medical diagnoses and medications that are needing to be evaluated? And as a whole, AI does offer that solution to one, take the idea to be proactive about our healthcare, to extend our providers in new ways, to try to move more of the care to their primary care, where we know is the most effective place of care for individuals with more primary care communities with more primary care visits per specialist visit have better healthcare. And how do we maximize that outcome? By finding ways to extend that primary care provider so that patients have easy access to the basic screening, to the basics of healthcare, so that when they are going to the specialist, they are getting what they really need. And that's what that number means. It's not that more primary care, more visits per specialist visit is a good thing. It's more primary care visits means that there's better screening, that there's better early intervention, so that specialists are being used more effectively.
Obviously, as a AI advocate, I really like that answer. And I think to lead off of that, as an early adopter, relatively early adopter of the technology, what is your perspective on what investments could be made from a research perspective that would build trust, the needed trust to continue down this path with clinicians and patients?
I think the big developments that need to happen to help build the trust is a couple fold, and I think they're all ones that will come with time, and I think time is the answer here. One, we need more presence in the community to build the trust with the rooming staff, with the patients, with just feeling more comfortable with it. They're already getting there. When they hear AI, they already know that this is happening in some way, shape, and form. And many of our radiologists on the flip side already know that they are more effective diagnosticians when they have AI helping them read the images. So it's coming. Primary care is a new application of this same technology that is already present with radiology, reading chest x-rays and mammograms and CT scans and other things. So this is a new application there. And as it continues to come forward, we have data showing that that the diagnosability is there, that we can look at the pictures and determine retinopathy versus no retinopathy. The next steps as a whole come from a couple fold. One, can we differentiate the different types of retinopathy in the eye exam space specifically? Two, just because are diagnosing the retinopathy early, what's the true outcome-based data based upon a vision loss, vision preservation? What's the intervention there? I know Luminetics is, I'm sure, looking at that actively right now, and it's a great area of research that as clinicians, as health systems start to look at this technology further, that would be the next step in putting the icing on the cake. We already see that to some degree with some of the radiology tests. It's only a matter of time before it comes with the digital diagnostics type eye exams and really gets us to that next level. It's coming. I trust in our AI partners that they will help us get there as we start posing the correct clinical questions, which we're starting to do here by asking, what is it that builds trust? Accurate exams, seeing it over and over again, and being able to speak to it. Having outcome-based data ultimately will drive provider decisions and will help provide provider buy-in, which will then help the staff buy-in and will help the patients buy-in. It's a cascading, and the critical mass is getting there.
I am very happy to be in this field at this time, working on hopefully getting some of those things out into the world. And I am very happy that you're here to talk about what that looks like in practice. This has been a really excellent conversation. I've enjoyed it, and I wanted to thank you, Dr. Eckelkamp, very much for being here, joining me, as well as, of course, SSM Health and the audience. Thank you, audience, for being here and being with us. We will be in touch with the recording if anyone would like to replay any of those answers. And then also, please do reach out to your representative and visit our website to learn more about digital diagnostics, LumineticsCore, and what that might look like for you. Thank you so much, everyone, and I hope you have an excellent rest of your afternoon, evening, whatever time